Hi everyone and welcome to our module on the introduction to antimicrobial pharmacology. This module is an introductory session to the topic of antimicrobial pharmacology. We will talk about some terminologies that have to do with antimicrobial pharmacology, classification of antimicrobials, some factors that tend to determine what antimicrobial drugs we prefer to use in certain situations, and then what we call resistance and then complications of using antimicrobial agents. As a form of introduction, it's important to note the definitions of important terminologies under the subject of antimicrobial pharmacology. First of all, we'll talk about the definition of antimicrobial agent, then talk about what we call chemotherapy, antibiosis, antibiotics, and selective toxicity. So an antimicrobial agent is a substance that is used to stop the growth or used in killing a microorganism, hence the name antimicrobial. They are used in clinical settings and they are usually grouped under the broad term chemotherapy. Now, chemotherapy, when we think about chemotherapy, we think about drugs that we use in treating cancers, in killing or reducing growth of cancerous cells. Now, while this is true, it's not a complete picture. Antimicrobial drugs should also be classified as chemotherapy. Chemotherapy, in terms of definition, simply includes agents that are that selectively eliminate or inhibit the growth of harmful cells. The cells could either be neoplastic cells or invading microorganisms. So on one hand, we have chemotherapy being divided into anti-neoplastic agents, and we have chemotherapy also being divided into antimicrobial agents. So antimicrobial drugs are also chemotherapy. But in the case of antimicrobial drugs, we use them in killing harmful invading organisms. In the case of anti-neoplastic agents, we use them in curing or killing neoplastic cells. And it's important to note that these drugs tend to work selectively on the organisms that they are targeting, and they have very minimum toxicity to the host. Another term for you to know is antibiosis and antibiotics. Antibiosis is the process of inhibiting the growth of microorganisms with substances produced by another microorganism. Now, antibiosis is a process. The second term, antibiotics, is actually a substance. We'll talk about that in the next slide. Antibiotics are a type of antimicrobial agents that are substances made from one microorganism and used to inhibit the growth or kill other microorganisms. Remember that antibiosis is a process, antibiotics is the substance or the agent itself. Now, just to quickly bring this in full circle, when we talk about antimicrobial agents, first of all, we start with chemotherapy. Chemotherapy would be any substance used in inhibiting the growth or killing cells, harmful cells. Chemotherapy could further be divided into antimicrobials. Antimicrobials are targeting invading organisms or microbes, hence the name. Or we could divide chemotherapy into anti-neoplastic agents, which are particular substances used in inhibiting the growth or killing neoplastic cells. Antimicrobial agents can further be divided into antibiotics, and antibiotics are special breeds of antimicrobial agents that are produced from microorganisms. So, for example, we can get an antibiotic from a plant, or we can get it from a fungi that are produced from one organism or one microorganism and they're used in killing or inhibiting the growth of another microorganism. Other type of antimicrobial agent we have are the synthetic agents. So synthetic agents are agents that are purely made from the lab. So we're not getting them from a microorganism, we're synthesizing them directly from the lab. So we are not going to call these substances antibiotics. Antibiotics are the ones gotten from microorganisms. And we have the semi-synthetic antimicrobial agents. Semi-synthetic antimicrobial agents usually tend to be um, classified as part of antibiotics in some textbooks. Just note this, that when we talk about the antimicrobials, first of all, antimicrobials are classified under chemotherapy alongside anti-neoplastic, and the antimicrobials are further divided into antibiotics, semi-synthetic antimicrobials, and then synthetic antimicrobials. Our major focus in the module under GPP would be on antibiotics. So all the drugs we talk about in GPP will be on antibiotics. Last terminology to remember is the terminology of selective toxicity. That is the ability to exploit biochemical differences or target sites that are relatively specific to the invading organism or tumor cell as compared to the host cell. So when you're using a drug that is a chemotherapy or antimicrobial, this drug would have selective toxicity to the particular cell that we are trying to treat or kill or inhibit the growth. So in the case of antimicrobial, it's an invading microorganism. That particular drug would have large of the most of its activity directed at targeting the microbe that we want to eliminate. And then we have very few toxicity being seen to the host cell itself. And that's what selective toxicity means. So when we start talking about some of the drugs, you see that most of the microorganisms have particular biochemical differences or sites that we don't see in the host cell, and as a result, it allows the invading microorganisms to be vulnerable to the antibiotic or to the antimicrobial agent that we're using to eliminate them. How do we classify antimicrobial agents? We can classify them in five different ways. We can classify them based on the microorganism we are trying to eliminate. We can classify them based on their mechanism of action. We can classify based on the effect of action. We can also classify based on the spectrum of activity, and then based on their chemical structure. Usually, we prefer to use the classification based on mechanism of action and a bit as well based on the chemical structure. We'll talk about each of these classification and the examples under each of them. Starting with classification based on the microbial organism, this is very straightforward. So, types of antimicrobial agents, depending on the microbial organisms, includes antibacterial. So these are drugs used in eliminating bacterial organisms that are causing infection in an individual. Antifungal are used in eliminating fungal. Antivirals are used in eliminating viral infections. Antiprotozoa, these are used in eliminating parasitic infections. Same thing with anti-helminth. Anti-helminth and antiprotozoa are both anti-parasitic agents. So they're involved in eliminating parasitic infections like Entamoeba histolytica, or even infections caused by worms, so nematodes or trematodes. We have classification based on the mechanism of action, and in this particular classification, we would focus largely on two of this set of drugs in the next module. So the drugs or antimicrobial drugs classified using this particular criteria include cell wall synthesis inhibitors. So these are drugs that will be targeting the cell wall of the microbe. We have cell membrane disruptors, very similar to cell wall inhibitors, but they are focusing on the cell membrane of the cell wall. Then we have protein synthesis inhibitors. We have the DNA gyrase inhibitors, DNA synthesis inhibitors, and then we have the antifolates. A major focus in the GPP section of your pharmacology will be on cell wall synthesis inhibitors, focus on drugs like penicillins and cephalosporins. And then we'll also talk about the protein synthesis inhibitors. We'll talk about drugs like the macrolides, like tetracyclines, chloramphenicol, and aminoglycosides. We'll talk about each of these in our next module. Then we have drugs being classified as bacteriostatic or bactericidal drug. This classification is based on the effect of action. I'll talk about what this means in the next slide. So bacteriostatic drugs are drugs that can cause reversible inhibition of growth. So this one are drugs that tend to inhibit the growth of a particular microorganism. But once they inhibit the growth, the particular inhibition tends to be reversible if the drug is being removed as a result. So when this antibiotic is removed, the bacteria will start to replicate again, and as a result, infection will be propagated from there. Bactericidal drugs, on the other hand, are drugs that tend to cause irreversible inhibition, or we tend to say they tend to cause death or kill the microorganism that we're targeting. So even if we remove the antimicrobial agent, the bacteria cannot replicate again because most likely bacteria has been irreversibly inhibited or killed. So it's very important to know the differences between the bactericidal agents and bacteriostatic agents and examples under each of them. So just remember that bacteriostatic stasis causes stasis in the microorganism's growth, and a removal of the drug would lead to the replication of the bacteria because the bacteria was just in stasis and can recover from it. Bactericidal agents, just remember cidal, like suicide, when you think about suicide, think about death. So bactericidal drug leads to final or irreversible inhibition of the microorganism. microorganism, and as a result, the removal of that drug will not lead to replication of the bacteria as a result. So examples of bactericidal and bacteriostatic agents are very important to note for your MCQs. So bacteriostatic agents include drugs like chlorphenicol, erythromycin, clindamycin, sulfonamides, trimethoprim, and then tetracyclines. Most of our protein synthesis inhibitors that we'll talk about in the next module are classified as bacteriostatic. Bactericidal agents include drugs like aminoglycosides, beta-lactams, vancomycins, quinolones, rifampicin, and metronidazole. And most of the cell wall synthesis inhibitors that we'll talk about in the next slide are bactericidal. We can also classify antimicrobial drugs based on their spectrum of activity. In this case, we have the narrow spectrum drugs, the broad spectrum drugs, and the extended spectrum drugs. And this is just based on how much of microorganisms that these drugs tend to cover. In the case of narrow spectrum, and narrow spectrum antibiotics would act only on limited groups of bacteria. So they could probably use them in treating one or two different bacteria infections and nothing more than that. For broad spectrum and extended spectrum, we use them for a larger set of bacteria. So an extended or broad spectrum drug could be used in treating infections caused by maybe 20 to 40 bacterium as a result. So they are very ubiquitous in terms of their action. Finally, we have the classification based on chemistry. And in terms of this classification, we tend to use this hand in hand with the classification based on mechanism of actions. We have drugs called beta-lactams based on their chemistry. We have drugs called aminoglycosides. We have the macrolides. We have tetracyclines. We have the chlorphenicols. This is purely based on how they look like. Sulfonamides tend to have the sulfur group attached to them. The sulfadiazines and the dapsones, quinolones, the azoles, the nitroimidazoles, nicotinic acid derivatives, and the nitrobenzene derivatives. All these are drugs, antimicrobial drugs classified based on the chemistry. The first five or first six drugs are the drugs we'll focus on in our module under GBP. So we'll talk about the beta lactams and the this includes cephalosporins and penicillins. These are classified as cell wall synthesis inhibitors. Then we'll talk about the aminoglycosides, the macrolides, the tetracyclines, and the chlorphenicols. These four drugs are all classified as protein synthesis inhibitors. So the first five drugs are the drugs that will be focusing on in the next module, next video, um, and we'll talk about each of them in terms of the different properties we need to note in terms of their pharmacology. Let's go to factors. What are the factors that tend to determine the selection of antimicrobial drugs? There are two major factors we should consider when we are selecting antimicrobial agent. Remember that we have a number of antibiotics in circulation in pharmacology, and what makes us pick a particular antimicrobial agent or antibiotic over another are two major factors: a drug factor and the patient factor. We'll talk about these factors in the next slide. Starting with the drug factor. So these are factors peculiar to the drug that would prevent or allow us to select a particular antimicrobial agent. The first is the dosage form. So the dosage or dosages forms of different antimicrobial agents could either allow or disallow us in using these drugs for treatment. The efficacy of a particular antimicrobial drug as compared to another will tend to also determine the selection. For example, when we talk about penicillins, we have different types of penicillin. We have amoxicillin, ampicillin, we have augmentin also being a penicillin. Most times, augmentin tends to be more efficacious than even the ordinary penicillins like amoxicillin. And just by virtue of the efficacy of augmentin, that might be a preference when we need to treat a very stubborn infection. And frequency of administration is also a determining factor in the sense that drugs that we need to prescribe multiple times in a day, let's say 4 times in a day, um, might not be well preferred compared to a drug that we need to just use once a day or once in 2 days for us to treat a similar infection. So frequency of administration tends to matter in terms of determining the selection of a particular antimicrobial agent. Route of administration also tends to matter. A very typical example would be the antimicrobial drug aminoglycosides. Aminoglycosides are not usually given orally, We prefer to give them IV because they're not well absorbed when we give them orally. So in the case of aminoglycosides, we will not be giving this drug or prescribing this drug to an individual that doesn't want to take an injection or take the drugs through parenteral means. So we prefer to give another drug that's quite as efficacious as aminoglycosides, but the drug that we can give orally. Then finally, adverse drug effect could also be a determining factor. So drugs like tetracycline and aminoglycosides, we prefer not to give them to some particular patients just because of the adverse reactions that we tend to see. Tetracycline, for example, in children can lead to stunted bone development and can lead to dental hypoplasia. And as a result, we don't like to give tetracyclines to children just by virtue of what it causes as an adverse effect at the bones and teeth level. These are just pictures to depict what we talked about already, dosage form of different drugs, and also route of administration is depicted in this image. You can see drugs given um, topically through the eye, drugs given orally, drugs inhaled, drugs given IV, and drugs given as topical form on the skin. These are just different dosage form and different routes of administration for different antimicrobial agents that can be used. The second factor that tends to determine selection of antimicrobial drugs are patient factors. So these are things that we see in a patient that would allow us to select one antimicrobial drug to compare to using another. First is the immunological status, and this is very key to note. Once a patient is immunocompromised or immunosuppressed, then we prefer to give bactericidal agents, right? Because bactericidal agents will be involved in clearing the entire microorganism present in the individual because the immune system is not up to par to clear that microorganism. A bacteriostatic agent, on the other hand, will just inhibit the growth and wait for the immune system to clear the microorganism from the system. So we don't give bacteriostatic agents to people that are immunocompromised. We prefer to give people that are immunocompetent bacteriostatic agents. But this is not the only factor. Other factors include the presence of a foreign body. Presence of a foreign body would make it difficult for the my antimicrobial agent to clear whatever microbe we need to clear because microbes tend to seed on foreign objects and they tend to evade antimicrobial agents or antibiotics once they are seeding on the foreign body. The age of the patient also tends to matter. Drugs like chloramphenicol tend not to be given to children or people that are below a certain age, usually newborns, because of adverse reactions that tend to occur at that age. This is by virtue of the fact that chloramphenicol is metabolized in the liver by a particular um, phase 2 enzyme, and that enzyme is usually lacking or reduced in amount in younger age groups. And once we give it to a person that is very young, chloramphenicol will not be metabolized in that individual, and that can precipitate an adverse reaction we call gray baby syndrome, which we don't want to see in that child. Underlying diseases also tend to affect selection. So individuals that have liver problems or kidney problems are people to watch when we give you a particular antimicrobial agent. The antimicrobial agents that are either metabolized by the liver or excreted by the kidneys. So if there's a kidney problem or a liver problem, or if the drug itself is nephrotoxic or it's hepatotoxic, we would prefer not to use drugs that way. So a drug like aminoglycoside tends to be nephrotoxic. So in that case, we don't want to give an aminoglycoside to an individual that already has a kidney problem. And that's the way in which underlying disease could determine selection of the antimicrobial agents we want to use. The history of drug allergic reactions also tends to matter. So people are allergic to penicillins and cephalosporins. So once we discover that they're allergic to a particular drug, we prefer to use an alternative drug. So like a drug like erythromycin could be an alternative drug to a person that is having penicillin allergies. Pregnancy and lactation also tends to matter. They're drugs that can be teratogenic, not just teratogenicity as well, but they're drugs that also have adverse reactions to the child. Vancomycin is a very common example. It could lead to it could lead to aplastic anemia in a pregnant woman, aplastic anemia of the child. It could also lead to gray baby syndrome in a child that is in a woman that is lactating and a child that is receiving breast milk because of the fact that that child's liver is not fully developed. And then finally, we have genetic traits. So this is what we call pharmacogenomics. This is how genetic traits could affect the efficacy of a particular antimicrobial agent. There are people that will say that, oh, you don't really like using erythromycin because it doesn't work well for them whenever they have an infection. This might be the fact that their genetics or genetic makeup does not allow erythromycin to work very well within them, and they prefer to use something like penicillin, which has a better efficacy in terms of their genetic traits. These are just images to show what we just talked about. A patient that has HIV is immunocompromised, and that type of patient will prefer giving um, and a bactericidal drug rather than a bacteriostatic drug in treating whatever infection the person is having. Right, this is just to show that age tends to matter. People that are older get a particular set of drugs. People that are younger might not get a certain set of drug, like maybe a chloramphenicol, because of the immaturity of their liver and their inability to metabolize a drug like chloramphenicol. Let's talk about resistance. So resistance is the ability of an organism to counter the effect of a drug. So once we are given an antimicrobial agent, one of the things that we fear or dread the most is the microbe being resistant to that drug. And there are different mechanisms by which a microorganism could resist an antimicrobial agent or antibiotic. And we'll talk about that in the next slide. The mechanisms by which antimicrobial agents can be resisted by the microbes includes one, spontaneous mutation of DNA, and two, DNA transfer. First of all, I'd like to separate these first two mechanisms. I prefer to talk about these two not necessarily as mechanisms of resistance or but mechanisms of acquisition of resistance. So let's first run through everything. Then I'll go back to what I mean by that. Then we have modification of target sites, decreased accumulation, and enzymatic inactivation. These are mechanisms of resistance. So first of all, the first two talks about how the microorganism would acquire resistance. So microorganisms could acquire resistance in two ways, either through spontaneous mutation of their gene or through the DNA transfer of drug-resistant gene from one microbe to another. So these are ways in which acquisition of resistance could occur for a microorganism. Please do note that. The remaining three mechanisms are mechanisms of resistance itself. So this is once they've acquired that resistance, how do they resist the antimicrobial agent that has been given to the individual to clear them? And so, first of all, is that it could modify the target site where the drugs will be working at. So, the drugs have different target sites. You can see that, for example, the target site for cell wall synthase inhibitors will be on the cell wall itself. So, one thing that the microorganism could do to prevent the drugs from working on the cell wall is by modifying the cell wall, modifying the target site of the drug. Once the cell wall has been modified, that will prevent the drugs from interacting with the cell wall, and that drug cannot do any harm to the microorganism. Another example will be in protein synthase inhibitors. Drugs that are protein synthase inhibitors will act on the ribosomes. So one thing that the microorganisms could do to resist the drug is that they could modify the ribosome. And once they modify the ribosome, the drugs will not be able to bind on the ribosome and do their work as a result. Another way in which drugs can be resisted by a microorganism is through the decrease of accumulation of that drug. Most drugs or most antibiotics tend to enter into the microorganism for them to perform their action. So if you look at this particular image, you can see that drugs tend to first of all enter into the microorganism for them to act on their target site. So one thing that the microorganism can do is that they can reduce the accumulation of drugs within their cytoplasm, either by the use of what we call an efflux pump. You can see in this case, there's an efflux pump. Once the drug is entering into the microorganism, the microorganism will pump the drugs back out into the exterior environment through the efflux pump. Or they could even prevent the uptake in the first place of the antimicrobial agent. So it actually decrease uptake or increase in the ejection of the drug through an efflux pump. These are ways in which they can decrease accumulation and reduce the chances of the drug being effective on the microbe. Then finally, we have what we call enzymatic inactivation. This is the process whereby a particular microorganism will produce an enzyme. That enzyme that is being produced has one function. That function is to destroy the drug itself. So once the drug has entered into the microorganism, the enzyme is produced, and the enzyme will just inhibit the drug. As you can see, inactivating enzymes are just destroying the drug that has been sent to destroy the microorganism. Thereby, the microorganism will resist um, the harmful nature of the drug. Now, what are the causes of antibiotic resistance? One would be overuse of antibiotic agents, so overprescribing antibiotic agents, and this is commonly seen in our environment when an individual has just a cough or just small fever. They're already self-prescribing drugs to themselves. This will give the bacteria or the microbe enough time, enough chance to develop resistance to the drug that we're using. So it's important that whenever we have a symptom or symptoms of infection, we testing ourselves to know what particular infection we're having before we use antimicrobial agent. There are particular infections that we don't even really need antibiotics for. So viral infections are not really infections that we treat with drugs, except there are particular viral infections that are very, very life-threatening. Another cause of antibiotic resistance will be patients that are not taking the antibiotic drug that's prescribed. So whenever we're given a prescription, it's important that we use the drug continuously until the end of the particular prescription that was given to us. Because if we don't use that drug completely, the microbe within the system will develop ways quickly that would help it in resisting the antibiotic. Other causes of antibiotic resistance include unnecessary antibiotic use in agricultural animals, poor infection control in hospitals and clinics, poor hygiene and sanitary practices, and lack of rapid laboratory testing. These are all ways in which antibiotic resistance will result. What are the complications of antibiotics? First is direct toxicity. Drugs could either be directly toxic in a local site or a systemic site. So you can have local irritation or systemic irritation. For example, local irritation would be maybe when you're injecting a drug. Once just injecting the drug through the skin could have the person could have skin reaction at that point. Or there are drugs like penicillins that once we inject them, we could have a systemic irritation. And another form of complication could be hypersensitivity. This is quite seen in penicillins. Penicillins, people could have sensitivity or allergic reactions to penicillins, and then they start to have different symptoms as a result of the allergic reaction. And what we call super infection, this is a very funny complication because in super infection, what happens is that because we are using an antibiotic agent to clear one organism, that could lead to another organism that is not being cleared by that antimicrobial agent growing wings, quote unquote. And as a result, that other organism will now start to cause infection. So we can say that maybe one of the organisms we're trying to clear is keeping the other organism in check. Is more of the boss keeping the other organism in check. So once we clear that first organism, the second organism will have leeway to grow and propagate infection as a result. So this is what we call super infection. Give you an example of what this means in the next slide. Then we have nutritional deficiency. There's some particular drugs that could lead to poor nutritional, not poor accumulation of nutrients in the body because of the use or mechanism of action of the drug. As a result, this can lead to nutritional deficiency in the individual. Then we have marking of an infection. This could also be a complication of use of antimicrobial agents. This is a picture of someone having a local irritation as a result of, or maybe systemic irritation as a result of the use of an antimicrobial agent. It's probably due to the use of sulfonamide. Sulfonamide is notorious for causing skin reactions we call Steven Johnson syndrome. Right? Local irritation can also come in the case of vomiting, with direct toxicity to the GIT and we take a drug orally. So we can say that in most of the antimicrobial drugs, the penicillins, cephalosporins, and monoclagosides or otherwise. Allergies and hypersensitivity reaction we can see to drugs like penicillins and cephalosporins. And then super infection is typically seen in a condition we call pseudomembranous colitis. This is when we use a particular antimicrobial agent. Taking that drug orally can clear off normal flora present within the GIT, and this will allow for another normal flora that is being kept in check called Clostridium difficile to start to grow at an uncontrolled rate. This Clostridium difficile that has started growing will now lead to a secondary infection, a second infection, what we call the super infection. And that infection is what we call pseudomembranous colitis. This is an image of an individual that has pseudomembranous colitis. You can see that the GIT has become colonized by the Clostridium difficile and is leading to different inflammation or and ulcerations within the GIT. This is just by virtue of the fact that the person used a particular antibiotic, maybe clindamycin or a cephalosporin or aminoglycoside, and that drug was just too powerful for the GIT. It cleared the infection, but alongside that, it propagated the growth of led to the propagation of the growth of Clostridium difficile within the GIT, and that worsened the situation of the individual. And that concludes our module on the introduction to antimicrobial pharmacology.